Hello, and welcome to Basics to Brilliance Haematology Podcast, the podcast series that will take your basic haematology knowledge up to a level needed to be an effective haematology registrar. We hope that the content we cover here will help you prepare for the dreaded Haematology FRC Path Part 1 examination. But most importantly, we hope that this series fills you with excitement for the fantastic, dynamic and highly rewarding specialty of haematology. My name is Dr. Anharad Everden, Haematology ST5 Registrar in the Southwest Deanery.
And my name's Dr. David Fazy, Haematology SHO, with aspirations to be a haemareg.
And my name is Dr. Sayed Haider Jaffrey, Haematology SHO and aspiring haematologist.
And let's get started on today's topic.
From basics
to brilliance. Hello, hello. It's the Three Musketeers again.
We're back for more punishment.
David!
I mean, more education.
Punishment. Unbelievable. Right, today we're doing how to diagnose von Willebrand's disease, essentially, in a nutshell. We're going to go through the lab tests, and basic that's, and then I've got loads of cases for you to test you.
Can't wait.
Yeah, good. I hope that's not sarcastic. But first, let's start with our homework that our lovely men here volunteered themselves. What was yours, Hader? I've got something about glycosylation of von Willebrand's in diabetes. Tell us.
Yeah, so I found one article in Science Direct from March 2025 asking the same question. Basically, it says that it could... So glycation of von Willebrand factor could contribute to macrovascular complications in hyperglycemia and diabetes.
Okay.
It might be site-specific.
Okay, so we're thinking that maybe in really bad diabetes, you might have more glycosylation of your von Willebrand factor, and therefore you might get slightly higher levels of von Willebrand factor, which might cause blood clots.
Yeah.
Okay, makes sense.
Yeah.
And
I need to dig in a bit more, but yeah.
Yeah. And David, I wrote down Adam TS13, but I don't know what it was about. I can't remember.
Yeah, where is it produced? It's made in the liver.
It's made in the liver. There we go.
Which makes some interesting, some interestingness, because I guess if you have severe liver disease, you can end up in this sort of clotty but also bleeding kind of state.
Oh, I did know that. Yes, it's with the whole rebalancing of hemostasis thing and chronic liver disease. Yeah. Damn, I knew that.
Yeah. So, it can contribute to portal vein thrombosis, but the fact that you also have low coagulation factors can also make you very bleedy.
Oh, yeah. So, we're going to do a whole episode on coagulation in liver disease because it is fascinating.
Yeah. Don't drink too much, folks. There you go. In a nutshell.
Yeah. So, Adam TS13 is also made in the endothelium. Note as well.
Okay, is it? Right, okay.
Just to add, vascular endothelium as well.
Oh, Hader, he's correcting your homework, David.
See, David's done so many
when are you going back?
back?
We need to get this guy off the microphone.
Okay, right. So let's start with how do we diagnose von Willebrand's disease? Let's cut the chat. So bleeding history is the first thing. Okay, we've talked about that already. We've said how 1% of the population will report abnormal bleeding, just in a general population. That's why we get a lot of referrals to the H&T clinic. And the question is, how do we detect those that think they have abnormal bleeding and truly have abnormal bleeding? What tool did we say we were going to use from last time?
IHS
something BAT.
Yes, the BAT, the ISTH BAT, International Society of Thrombosis and Hemostasis Bleeding Assessment Tool. Very good. And we said in particular, bleeding from a superficial cut, more than 10 minutes sort of predicts that you do have a bleeding problem. And we talked about menorrhagia and how in particular we can pick that up from what is considered normal within a family when it's often not normal. Good. So bleeding history is the first one, and we're looking for a mucocutaneous type bleeding pattern in the majority of types of von Willebrand's disease. Which one would we expect not to see so much of a mucocutaneous bleeding pattern?
Type 3?
Type 3 can sometimes be a bit haemophiliary because of the complete absence of von Willebrand factor, so a shorter half-life of factor 8, yes. And what's the other one?
2M?
2N?
2N.
No, number 8.
Yes.
Yes, very good. I'll take that. I know you said M, but we'll pretend you said N. Good. Okay, so then next is the coag screen. So we're going to do our standard coag screen that we all know and love for blood count, PT, APTT for Brinogen. What are we expecting to see?
Probably normal for the PT and APTT.
Good. I'm glad you say that, David, because remember, this was one of our key diagnoses that has a normal coagulation screen, and that this was one of the examples of how in a pre-op clinic you need to take a bleeding history to be able to diagnose the most common bleeding disorder that exists, i.e. von Willebrand's disease. So your PT and APTT are largely going to look normal, except in which one?
The one that binds factor 8, N.
Yeah, exactly. 2N for no number 8 and type 3 as well. Can potentially both prolong the APTT because of the factor 8, as we said. Good. And what about the full blood counts? Any one that you would potentially see something different in?
2B can cause thrombocytopenia.
Yeah, very good. Exactly. Okay, excellent. So we do our coag screen. It largely looks normal, but therefore we're even more like, okay, this could be a von Willebrand's disease. So then we do our von Willebrand's disease screen, and as we said last time, you need to do this test twice, okay? Because it's not very reliable, basically, and you also need to do it in somebody who's over the age of 6 months, because stress puts DDAVP up and then causes a release of von Willebrand factor. It's very hard to take blood. I mean, it's very hard to even get breast, let alone take blood off my child. So like, if you imagine a child under the age of 6 months, they are going to find having a needle distressing, and so it can just make results really unreliable. So we would usually say, the only exception is you would test a newborn if you were expecting type 2B or T3 or type 3, because type 3 you're going to need to start some sort of replacement early, and with type 2B it means that it does affect management because you don't want to increase their endogenous levels with like DDAVP. So in those situations you would test a newborn if there was a family history and you were worried that they were going to be born with with either 2B or 3. But otherwise, you would usually wait until the child actually develops a bruising or some sort of bleeding history, which seems a bit mad. But the thing is, it's variable penetrance, so there's no need to do the test, because if you haven't got a bleeding history, you can't make a diagnosis anyway. It's not just based on lab tests. So you would usually wait until they actually develop some sort of clinical reason to test them, and you would wait until after 6 months. Okay. And then your basic von Willebrand's screen consists of 3 tests. What do you think they are?
Antigen test.
Yeah.
Activity.
Yeah.
Yeah.
And the 2 R words that I don't remember. Riker?
So Rickoff. The Rickoff is the activity. Okay. So we abbreviators are big C, little o, Rickoff. And that is your activity test, your functional test. So you do your antigen, you do your functional test or your Rickoff. And then the third thing that forms an important part of a von Willebrand's disease initial screen is your factor 8 levels.
Okay. Did you say that was the Ripper test? Was that the one, or was that
No, Ripper is a separate test that we'll come to later.
I'm sorry, I'm getting ahead of myself.
Yeah, that's the subtype, twos. Okay, so just your initial basic von Willebrand's disease screen, because remember, most of your von Willebrand's disease is going to just be boring old type 1, which will be easy to spot. You'll have low antigen and low activity with a normal ratio. Okay, so like, I don't know, a level of 20 and an activity of 20, and that's it, you're done. That's like 75% of von Willebrand's disease. So for most, you don't need to go on and do all these other fancy tests. You just do antigen, you do activity, which is in the form of a Rickoff, and then you do your factor 8 levels, okay? Because you want to exclude mild haemophilia A. Okay, and then further lab tests that you can do are then things like your factor 8 binding assay, your Ripper, and your measurement of your multimers, your high molecular weight multimers for 2A versus 2M. Okay? And then finally, one of your other lab tests that you should probably know a little bit about is the DDAVP trial. And that's where you give somebody DDAVP and then you measure their von Willebrand factor, a bit like how we do the DDAVP trial in haemophilia A patients, young patients, where we want to basically document that they do respond and to what level they respond, so that we know how useful or unuseful that would be clinically in a state of bleeding. Okay, and that can be diagnostic, particularly for your 1C, where you're going to see a peak that goes up and comes down really quickly because it's being cleared too quick. Okay.
Yeah.
So those are all your tests. So you've got your bleeding history, then you've got your standard coag screen, then you've got your von Willebrand's disease screen, which is your activity, which is a Rickoff, your antigen, and your factor VIII. And then only at that point, you may or may not need to go on and do further lab tests to then subcategorize, which is going to be your factor VIII binding assay, your Ripper, and your assessment of high molecular weight multimers, and then your DDAVP trial, which is also kind of part therapeutic as well. Okay, so
I'm going to say something ridiculous, which I don't think we're going to. Acquired von Willebrand disease?
We will come to acquired when we talk about, but I think we should leave that until we get to there are definitely clinical syndromes where you get an acquired von Willebrand disease. We're going to leave that until we get to the clinical side of things, and we'll talk about.
Okay, great. I just, I was just thinking about it, and I was like,
right.
Surely there's a.
It's not in the same. It's not like acquired haemophilia A. It's usually so. It's not like an autoantibody type thing. I mean, it can be, but it's usually things like Wilms tumors, where the von Willebrand factor gets bound to Wilms tumors in children. Or you can get an acquired von Willebrand's disease in MPNs, JAK2 MPNs, where the platelets bind the von Willebrand because the platelets are faulty. So we will come to that, but
I'll put that back in the box.
Put it in the box. Because that's going to be that's going to be a much older age group that are going to present, or it's going to be a child that's presenting in the context of something wrong, or like a leaky heart valve. There'll be something else to make you think about acquired von Willebrand's disease. But the lab tests are the same, David.
Okay.
The lab tests would be the same, and you would do your initial von Willebrand's disease screen with the activity, the antigen, and the factor VIII level, and then you would go from there. Yeah.
Yeah. Okay.
Okay, great. So let's talk about just measuring the antigen level to start off with. So does anyone have any idea how this lab tests work?
ELISA.
It's an ELISA. Good. Yeah, an ELISA. And basically you have rabbit anti-von Willebrand antibody coating a well, and then you basically add the patient's platelet poor plasma. It's always platelet poor, so we've spun it loads so that all the platelets are out of it as well. And we've taken the supernatant right on the top, because obviously platelets contain von Willebrand factor, so we don't want that to be complicating. So we take the rabbit anti-von Willebrand factor antibody coated well. We then add in the patient's plasma. We then wash it, and then that washes off any von Willebrand factor that's not. It washes off anything that's not von Willebrand factor, and then we add an anti-von Willebrand factor antibody with a fluoro tag on it, and then we wash it again, and then we measure like how much of the fluoroscopy is created. So that's essentially the methodology of it. And so it gives you a total level of von Willebrand factor in the blood. And nowadays you can do like more latex immune assays, like AccuStar things, where you've got latex particles coated in antibody against von Willebrand factor. But essentially it's the same thing. Just imagine it as a well or a bead. It doesn't really make any difference. And you're measuring it based on binding to an antibody. Okay. So what was the level at which we were interested in it being type 1?
30 international units per deciliter.
Yeah, so less than 30, you're like, okay, this looks like type 1, repeat, and it should be less than 30 again. What if it's
more than one?
Sorry?
But more than one.
But more than one, yeah, very good. Yeah. Very good. Yeah. And we said generally less than 10 is a severe type 1. But then what if it was between 30 and 50?
It's not clinically significant?
Well,
it depends on the bleeding history?
Exactly, Hader. It depends on the bleeding history. You know, if you've got somebody with a bleeding history and their level comes back between 30 and 50, you're going to want to repeat it, because actually, like, it could just be on the day that they had more DDAVP floating around, and so they released more von Willebrand than they normally live with. So you would probably repeat if it was between 30 and 50. If it's above 50, however, then you're not going to repeat it. Okay, so that's a negative result. It's not type 1 von Willebrand's. Okay. And if it's above 100, then that can exclude von Willebrand's disease on a single test. So you don't even need to do 2 tests. If it comes back as 100, even on one occasion, that's got a negative predictive value of 90 to 95%. So just stop testing. Think of something else. Okay. So even if they've got a bleeding history, they could have a platelet disorder or haemophilia or something else, but you can be rest assured it's not type 1 von Willebrand's. Okay. And then type 1C. So how do we tell the difference between type 1C on lab tests? Would we be able to tell based on just the antigen level?
Do you test ADAMTS13 levels?
No. As in we do, but not for von Willebrand's.
Okay.
Because it's a bit indirect.
1C is destruction, isn't it?
Yeah.
Some more destruction.
Mm-hmm.
Do you use DDAVP?
Exactly.
And the time to destruction, essentially.
Yeah. Exactly. So it will go up at 30 minutes, and then at an hour, it's already gone back down again in 1C because it's being cleared really quickly. There are other tests you can do where you look at the propeptide to antigen level. So you do an ELISA for like propeptide as well, which is like the pro form. And so if you're making loads but it's getting destroyed, then the propeptide will be higher than the total antigen. But most places don't do that. So good. Okay, so that's how you do the antigen. So then how do we do the activity?
Good question.
Okay, fine. So we've talked about this Rickoff thing. Okay, so Rickoff is basically an abbreviation for the ristocetin cofactor activity assay. Okay, and ristocetin is basically an antibiotic that was a complete flop. Okay, and the reason why is because it caused a really bad thrombocytopenia, and it does this because it causes platelet agglutination and then clearance, a bit like R2B, where we get platelet agglutination and clearance. And it was discovered that basically ristocetin is able to bind to von Willebrand factor and unfurl it. And so it basically, you can think of ristocetin as shear stress in your head. It's the lab way of mimicking shear stress to make our globular von Willebrand factor protein unfurl into the spring shape and to bind platelets with the GP1B receptor. Yeah? So what you can do is, because we've discovered that ristocetin can induce this conformational change and make the von Willebrand factor unfurl and cause adhesion to collagen and platelets, we can use ristocetin to allow us to bind von Willebrand factor. We can use ristocetin to allow us to measure the activity and the ability of von Willebrand factor to bind platelets to collagen, yeah, or to bind platelets, the GP1B receptor. Are you with me?
Well, but what are you actually measuring?
So we're measuring, when we talk about that's a really good question, David. The activity that we're measuring when we do lab assays when we say activity of von Willebrand's factor, what we are talking about is specifically just the activity of von Willebrand factor to bind GP1B. So it's actually, in a way, a bit neglectful because we know there are 3 roles of von Willebrand's factor, and the lab test is only testing the ability of von Willebrand factor to bind GP1B. And we know that the GP1B receptor on platelets is the one that allows the most important role of von Willebrand's factor to, well, arguably the most important role, to bind platelets to collagen in that initial primary hemostatic plug. The lassoing role with this.
What's the actual measurement? Because you can't measure the volume of 1B available. It must be measuring
unbound platelets that are left afterwards.
Yeah, so good question. So it used to be done by doing platelet aggregation. So what you do is you add ristocetin to patients' platelet poor plasma, and then you add reference platelets, which obviously contain GP1B, and then you measure the amount of agglutination of platelets caused by the von Willebrand factor binding GP1B through luminagometry. Oh my god, I can't.
You got this.
No, I can't say it. But basically, it's platelet aggregometry essentially. So as the platelets aggregate together, it reduces the light that passes through, and then that's measured, like our platelet functional test that we do when we'll talk about platelet disorders on a different episode.
So it's almost like a clotting time.
In a way, yeah. Yeah,
Okay.
exactly. But then obviously it's not great to use platelets, to use real life platelets. It's it's a bit dodgy because different lab platelets could be different, etc. And it adds a whole load of variability. So now we have a platelet independent version of the Rickoff, which is basically where you have latex beads, which are coated with they're coated with recombinant GP1B antigen. And so it's like a fake platelet, basically. And so you add ristocetin and patient's platelet poor plasma to the recombinant GP1B antigen covered latex beads, wash, and then add an antibody to see a bit like an ELISA, I guess.
Yeah.
But instead of it being a well, it's on a latex bead. So you have a latex bead covered in GP1B. You add the patient's platelet poor plasma and the ristocetin to activate their von Willebrand factor, and then you wash it, and then to wash away any von Willebrand factor that didn't bind to GP1B, and then you add an antibody against von Willebrand factor with a tag on it, and then you measure the amount of luminescence created. Does that make sense?
Okay.
Yeah.
I think the key thing to understand is that ristocetin is a key ingredient because in the globular form that the von Willebrand factor floats around in, without shear stress, it can't unfold and it can't bind GP1B. So this discovery that ristocetin unfurls the von Willebrand factor means that we can actually measure the function of von Willebrand factor as it functions in the blood by being able to bind to GP1B, which it can only do when it unfurls in shear stress in real life. Does that make sense?
Yes, I'm just trying to work out in my head how I plug that number into a ratio of against.
Well, it spits out a number like 30 or 20, and so again, like sort of less than 30, you're thinking, that's weird. But it's not so, the activity is not so binary as the antigen level because it's about how the activity compares to the antigen.
Yeah, okay.
Because if you had like an antigen of 100, but the activity was 50, then that still implies there's a functional problem with your von Willebrand factor, even though you've got enough.
Yeah.
Does that make sense?
Yeah.
Although you would wonder with an activity level of 50 why they have a bleeding history. And so you'd also want to make sure you're definitely excluding other bleeding causes. Yeah.
Would you do the activity twice as well?
Yeah. Yeah.
Okay.
You do the whole von Willebrand screen twice, activity and antigen.
Oh, okay.
Because you can see they're both pretty unreliable in a way.
Yeah.
Yeah. Okay. So we've got antigen, which is done with an ELISA. And then we've got activity, which is done by adding ristocetin to do what's called a Rickoff or ristocetin cofactor assay. So that's what Rickoff stands for. And now we do a GP1BR, which is basically ristocetin, but using a latex bead or an ELISA-based method so that we don't have to use platelets from the lab. Okay?
Yeah.
So that's the antigen and the activity. And then the next thing is I've got some examples to test your understanding. Okay.
You can tell that David and I are really racking our brains right now because we can't make any jokes because
I know,
using
you're
all
really
our brain power.
There's no jokes today, guys.
I know, it's spooky. I'm like, what's going on? Am I depressing them, or are they just really thinking hard?
We're thinking.
I'm not used to you thinking so hard.
Yeah.
I'm not used to
You don't do it that often, yeah.
Okay, so right, tell me what your interpretation is of these results. I'm not giving you vignettes or anything. Let's just assume they've all got
doing it one
bleeding
at a time.
Yeah, okay, yeah. So we'll start with you then, Hader. So activity 28, antigen 28.
That's a ratio of 1, but the antigen level is low and corresponds with the activity as well. So we're looking at type 1.
Yeah, and obviously all of these are just first results, so you would repeat in all of these.
Repeat it again.
Yeah. Okay, good. David, activity of 15, antigen of 30.
So the ratio is 0.5.
Yeah.
So that sounds like a type 2.
Yeah, good.
And then we do more
tests. Yeah, okay. Hader, activity of 15, antigen of 28.
That is a ratio that is below 0.5.
Anyway. It's below 0.7.
Yeah. So
remember, it's always activity to antigen.
Yeah. So
it's a ratio of 0.54. I wouldn't expect it.
Yeah.
Head, yeah.
So it's type 2.
Yeah,
and then,
good.
Again, we go on further tests.
Yeah. Okay, David, activity of 1, antigen of 9.
This is a trick. Because the antigen's lower than 10, which means I can't do activity stuff. I remember. So yeah, because is it because the antigenic level's less than 10, the activity scale becomes unreliable?
Yeah.
So this is a type 1, a severe type 1.
Oh, he's very good. I can't believe I think wow, you fall into my holes.
We've been thinking, Harry.
This is what happens when I shut up and don't speak.
I know. God damn it, you concentrating today. Okay, Hader, activity of 0.5, antigen of 0.9.
That's going to be type 3.
Yeah, very good. Exactly. Yeah. Again, he didn't fall into the trap. Okay, David, activity of 50, antigen of 50.
With a bleeding history?
Very good. So we would repeat the test. Could be a mild type 1. Consider if bleeding history. Very good. Okay, Hader, activity of 30, antigen of 30.
Well, this is very borderline, isn't it?
It's borderline. It's the same. You're going to say the same thing.
Yes.
Is there a bleeding history? Repeat it, etc. But it could be a type 1. Yeah,
history,
exactly. And then last one, David, activity 60, antigen 60, factor 8, 20.
That's mean. Is this no factor 8? No factor 8.
Yes.
a type 2N.
Yes, exactly. 2N, nice. Or it could be a mild haemophilia A.
Okay.
We don't
do that to us.
Yeah, very good. Excellent. See, you totally get it, guys. Very good. Oof. I mean, that was basically every scenario you could possibly have had. Nice. Right, so I think you're ready to move on to the additional lab tests for further classification. We're on the home straight.
Thrilled.
Okay, so when we go through these lab tests, I want you to make sure you're asking yourself every time, what is this lab test designed to tell me? Okay?
Okay. Yeah.
And then you won't lose your way. And there's not too many. Okay, so we're going to start with the factor 8 binding assay. So the factor 8 binding assay is looking at how well your von Willebrand factor can bind factor 8. It's looking at that third role of factor 8 to carry factor 8 around, okay? So you would be doing this in a patient that's come back with a low factor 8 level and you're not sure if it's haemophilia A or if it's a type 2 N von Willebrand's disease, a no number 8, okay? So that's when you would be doing it, and it's telling you, is this haemophilia A or is it type 2N? Okay, so it's essentially a very simple ELISA-based technique. You have a well, which is coated with antibody, which is anti-von Willebrand factor. Then you add your patient's platelet-poor plasma containing von Willebrand factor, and then you wash. Okay, so that von Willebrand factor is bound to the well. And then that von Willebrand factor at the moment is containing factor 8. So then, hang on, let me just check my notes for this. Give me 2 seconds, because there's a certain substance we use to strip that factor 8 off. Yeah, here it is. So we then add calcium chloride to strip off the endogenous factor 8 that's bound to the von Willebrand factor. Yeah?
Yeah.
Because if it's already bound to factor 8, we can't measure how well it can bind factor 8. Okay? So we strip off that factor 8. And we want it stripped off because we want to control how much factor 8 we add to the von Willebrands. As, you know, you could have 100% of your von Willebrand factor carrying factor 8 because you've got super high levels of factor 8 in your blood. So that's why you have to strip it off to standardize it. Am I making sense there? Yeah. And so then you strip off the factor 8 and then you apply a fixed known concentration of factor 8 to your well. And that will allow your von Willebrand factor to bind factor 8 depending on how well it is able to bind factor 8. Hence, it's called a factor 8 binding assay, clues in the name. And then you wash it and you add an antibody labelled, which is anti-factor 8, to measure how much factor 8 has bound to the von Willebrand factor. Does that make sense?
Yeah.
Hader, are you with me as well?
I think so.
Okay, let me just recap. So you've got an ELISA with wells coated with anti-human von Willebrand factor antibody. You add the patient's platelet poor plasma samples containing von Willebrand factor factor VIII complexes. Yeah. The complexes bind to the plate via the von Willebrand factor antibody and via the von Willebrand factor. You wash the plate to wash off all the gubbins and anything that's not bound. Then you add calcium chloride to strip off that endogenous factor VIII that's currently bound to that factor VIII von Willebrand complex. So you've just got the bare von Willebrands anchored to the well of the ELISA. You then apply a fixed concentration of factor VIII to that immobilized von Willebrand factor of your patient. You then wash it so that any factor VIII that's not bound disappears. And you then add your anti-factor VIII antibody with a colour probe attached. And then wash and then measure the amount of light produced.
Okay. So is it ELISA with an extra test, with the extra calcium chloride, essentially?
Yeah, the calcium chloride is just because you need to strip the endogenous factor VIII off the von Willebrand to be able to measure how much factor VIII the von Willebrand can measure. And so it's basically a way of anchoring your patient's von Willebrand factor to a well, strip off the factor VIII, and then add a controlled amount of factor VIII to see how well it binds factor VIII.
Okay.
Hence, it's called a factor VIII binding assay. So in a 2N homozygous patient, your von Willebrand factor is going to bind very little factor VIII. In a
2N homozygous.
In a 2N heterozygous patient, you're going to bind some factor VIII, and in a normal patient, you'll bind loads of factor VIII because your von Willebrand will be binding it well. Does that make sense?
Yes. Yeah.
Okay, lovely. So that's factor VIII binding assay. I think that's relatively simple, and the clue is in the name.
Yeah.
Okay. So then next we've got Ripper. So you're not a true hematologist until you know what a Ripper is. Okay. So this is like cool lingo about the town, about the lab. Okay. This is the Ripper. Okay. So it's the ristocetin induced platelet agglutination. So this is using our old friend ristocetin, which does what exactly?
It unfolds the multimer of von Willebrand.
Exactly. It's our mimic of shear stress. And then as a result, we can then measure how well the von Willebrand factor can bind GP1B receptors on platelets and agglutinate them, either through platelet aggregometry type methods where we measure the light going through, or with the latex-based, ELISA-based methods. And that's our RIC-off, right?
Yeah.
But if we use a super, super low concentration of ristocetin, it shouldn't be enough to unfurl our von Willebrands and to make it happen. Okay, it's too low. But if you've got a 2B, where you're bonkers for platelets, then even with a really tiny amount of ristocetin and only a really tiny amount of von Willebrand's factor, it can be enough to bind and use up the platelets because it's a gain-of-function mutation. Does that make sense? So in a Ripper, you're looking for 2B, and basically you get, in normal individuals, the low concentration of ristocetin is insufficient to initiate the von Willebrand dependent platelet agglutination. And if agglutination does occur at a low level of ristocetin, it suggests type 2B von Willebrand's disease, or the pseudo von Willebrand's, the platelet type 1 or the other. Does that make sense?
Yes, it does. Yeah.
Good. Okay. And then the way in which you would distinguish between 2B and pseudo von Willebrand's, where the problem is with the platelets, is just by doing the Ripper twice. One, by using the patient's plasma, so the patient's von Willebrand's factor with a reference lab platelet. And then you compare it to using the patient's platelets and lab or reference von Willebrand's factor, usually from cryoprecipitate, and then you compare them. Does that make sense? Because then you can isolate whether the low dose ristocetin is sufficient because the mutation is in the patient's von Willebrand's factor being too high affinity, or because it's in the GP1B receptor on the patient's platelets that's the issue. So you can just control for one and change the other. Yeah?
Okay.
Okay, brilliant. So that's the Ripper. And then the last one that we need to be able to distinguish between 2A and 2M, which honestly I think is of mainly academic interest, is to assess the presence or absence of high molecular weight multimers. Okay, so this test is distinguishing between 2A and 2M. We used to do it with just simple protein electrophoresis. So, the gels where you basically denature all the proteins and then you separate them out based on voltage and how far they move based on their size. Obviously, super labor intensive and quite difficult to interpret. Now we instead utilize the knowledge that we know that the high molecular weight multimers are better at binding collagen. And so this is why we would do a collagen binding assay. Okay, so we've done a factor 8 binding assay, which is looking at how well the von Willebrand's factor binds factor 8. And now we're doing a collagen binding assay, okay?
So would you just put collagen in the bottom of the well?
Yeah, essentially.
Okay, and then a similar process?
Exactly. Yeah.
And is it reliable? Because we know it's better, but it's not.
We use it as our measure. So if you had absent high molecular weight multimers, then you're probably not going to get much collagen binding. And if you have loads of high molecular weight multimers and they're maintained, then you're going to get good collagen binding. So that's what a collagen binding assay is doing. Is it's telling you about the high molecular weight multimers to distinguish 2A and 2M.
You have a binary result essentially. So it's either absent or there's a reduction. It's not quantitative.
I don't know.
In the sense that you're not quantifying it.
It is quantitative in terms of what your collagen result comes out at, but they'll probably give you the result as it was high or it was low, something like that.
Okay, yeah.
So collagen in the bottom of the well, then in goes the patient, platelet-free plasma, and then the fluorescent tag does that bind von Willebrand's?
Yeah.
Okay.
Yeah.
And that's how you get your value.
Yeah. Okay.
Yeah.
Any questions? That's it.
No. Surprisingly, no.
Yeah, well, that's it. Those are your extra tests. So it's not that hard. And then you've got your desmopressin trial that we said about. So that's where you just give desmopressin, so DDAVP, which can be given IV subcut, or it used to be intranasally, but it's really hard to get your hands on intranasal DDAVP these days. And then you basically measure it pre-levels of von Willebrand factor antigen, the activity, i.e. the Rickoff, and the factor 8 levels, pre-dose, 30 minutes after, an hour after, and 4 hours afterwards. And basically, you should get an initial rise at an hour, and then rapid clearance by 4 hours, okay? And sometimes it can even be back to baseline within 2 hours in 1C. And so that's how you would pick up a 1C, is by doing a DDAVP test. And then obviously there are genetic tests as well. And so genetic testing is now increasingly used to clarify the type, the different types of type 2. Particularly because we know that there are variations in how reliable the tests are in the lab. So genetic tests can be done, but you need to have done 2 sets of antigen and activity screen first before you're able to submit a genetic test. And you can either do the R121, which is just single gene analysis, looking specifically for von Willebrand's factor, von Willebrand's disease, or you can do the R90 panel, which is a more general panel looking for platelet and bleeding disorders. So those are the 2 different genetic tests you can do, but you need to have still done all these tests first to start off with. So let's now apply our newly acquired knowledge of all of the lab tests and diagnostics for von Willebrand's disease and go back to our original case that we opened our previous podcast with. So don't worry, I'm not expecting to remember it. 32-year-old man is referred to haematology from A&E following a severe episode of epistaxis, which was arrested by local measures. He required transfusions of 2 units of blood. He has a history of recurrent epistaxis and he has excessive bleeding following tonsillectomy aged 6. Initial investigations were as follows. Okay, so we've established a mucocutaneous bleeding history and bleeding post-trauma, which is kind of a standard pattern. Hemoglobin 86, white cells 16, platelets 480, so a normal platelet count. Von Willebrand factor antigen 30. Von Willebrand factor activity Rickoff 10. Factor 8 level 100. Collagen binding studies normal. Ripper reduced. And von Willebrand factor multimers normal. Talk me through these results. So what do you think about the antigen and the Rickoff result? So 30 and 10. What is that?
So I guess that's kind of borderline from a antigen quantitative point of view, but with the activity being quite so low, that looks like a type 2.
Yeah, good. So the ratio is less than 0.7.
Yeah.
Very good.
Yeah, that's so I'm going down my type 2 pathway.
Yep.
You said that the factor 8 binding assay was 100.
Mm-hmm.
Which is normal? Question mark?
Yeah, well, I had it wasn't the binding assay actually, it was just factor 8 level.
Oh, just the level. Okay.
Yeah, and it was 100.
Okay, which is okay.
That's not IU per DL. If anything, it's a bit high. But he has just been bleeding, so
the collagen was normal as well.
Mm-hmm. Collagen binding studies were normal. What does that tell you?
There's a presence of the high molecular weight multimers.
Yeah, excellent, David. Yep.
The Ripper was abnormal.
No, it was reduced.
Reduced.
As in, it wasn't positive.
It wasn't positive. Okay.
What does that?
So not type 2B.
Very good, very good. So what are we left with? It's not 2M. It's not 2B. So it's got to be either 2A or 2M.
2A because it's reduced, not maintained.
Is it reduced though? Collagen binding studies were normal, and von Willebrand factor multimers were normal.
Oh yeah, okay.
So what's
the Ripper? The Ripper was low.
The Ripper was reduced, and that tells you that it's not hyperactive. It's not bonkers for platelets.
Oh yeah, okay, yeah, that's bonkers for platelets. Yeah, so
the Ripper's the bonkers one.
2M then.
2M, yes, exactly.
Yeah.
So this
even though David's done all the maths on this one.
Yeah, I know.
So I've
worked it out. Hayden jumps in at the end and steals all the glory. Classic David, isn't it?
I was genuinely
just go back to your editing role. Go back in your box.
I was
I'm never going to be invited again.
Return to the shadows. Yes, exactly. Well worked through, guys. Very good, very good. Okay, excellent. And then I just found some other ones online just to try and test your knowledge as well with interpreting the lab tests. So
I'll do the work on this one. And
yeah,
then
okay.
David can take the thunder.
I'll try and take the credit.
Yeah, perfect. Yeah, you can swap over. You can snake each other. So this is a 32-year-old male who undergoes von Willebrand disease screening prior to a minor dental procedure. The lab results show a disproportionately low von Willebrand factor activity relative to his antigen, so the ratio is less than 0.6. Further multimer analysis reveals an absence of high molecular weight multimers. Which of the following subtypes is most likely?
All right. So we said the activity is less than 0.7, 0.6.
Yep.
Which is pointing towards type 2.
Yep.
And then we said, what did you just say?
Multimer analysis reveals an absence of high molecular weight multimers.
Absence. That's your cue, David.
Oh, it's an A. A for absence. Sorry.
David, come in.
David can be snaky. Yeah,
I know, it's not in his nature, is it?
Yeah.
Okay, good. Excellent. That is correct.
Sorry, just for my clarity, the collagen binding thing was reduced.
Yes, correct.
Okay.
Yeah.
Correct.
Not that we were given that. We were just told that the multimers, the high molecular weight multimers were low. Okay. Which sometimes they'll just give it to you that easy. But if they've just given you a collagen binding, yeah. Exactly.
Okay, great.
Excellent. Okay, so next question. A lab technician performs a von Willebrand disease profile on a specimen from a 23-year-old male who complains of easy bruising and frequent epistaxis. His results here are as follows. He's got a Rickoff of 25, an antigen of 28, and a factor 8 of 27. Based on these results and clinical history, what is the most likely diagnosis?
So his...
Go
on.
So low factor 8.
Yes.
But But he also has, sorry, I missed it. He's got an activity of 28.
Rickoff is 25 and antigen is 28.
Oh, they're very close.
Mm.
Okay, but he's also got a low factor. So I'm thinking this could be a type 2N. Could this be a problem with his binding to to factor 8? But we don't have a factor 8 binding study.
It could be, but David, the thing is, his antigen level is less than 30. So is it not just that he has less factor 8 because he's got less antigen around?
Are you saying this is a type 1, despite the fact we've been mining our way through type 2?
Yeah, that's right. That's right.
Oh, exactly. For goodness sake.
I never made any promises it was going to be a type 2. So there we go.
You know, if it makes you feel any better, David, I was literally like, type 2N. Yeah, it's type 2N.
It could be a type 2N.
This down.
It could be. But the thing is, like, the factor 8 is low, probably because the antigen is low. You're going to repeat all of those things. And also your bleeding history here is going to be useful, as is your inheritance pattern. You know, because the differential is you could have a mild hemophilia A with just maybe, you know, normal within the normal limits of von Willebrand factor levels as well. You know, they're less than 30 on this test, but the next one they might be more than 30. So we don't know. It's a silly question in a way, but it's pointing towards a type 1. Because it's a type 2N is more when you've got good antigen levels of von Willebrand factor, but your factor 8 is low. As with this, you've not got good levels of von Willebrand factor and your factor 8 is low. Do you get what I'm saying?
Yeah.
Because, you know, in type 2N, you could have like a von Willebrand factor antigen level of like 100. But then I'm exaggerating, but you could have like 100 von Willebrand factor antigen, and then your factor 8 is like 10. It wouldn't be that extreme, but you know, as in like, this is more it's more congruent. You would expect low factor 8 with low von Willebrand factor antigen. Yeah,
it makes sense.
Yeah. Okay. Cool.
I think once we're in the quagmire
and the ratio, and also remember the ratio is normal as well.
Yeah. Question for you. I'm sure you're going to make me search the answer afterwards.
Yeah.
DDAVP deficiencies, like diabetes insipidus.
Okay.
Would they have a quantitative reduction in?
No, they shouldn't on lab tests. They shouldn't. They just, because the whole point of you having a well-rested patient that hasn't been exercising, isn't stressed, doesn't have an acute infection, isn't dehydrated, etc., is that you're just trying to measure the constitutively released von Willebrand factor, not the additional stuff that you would release in stress. So let's say, and also in diabetes insipidus, I think it's about receptor sensitivity to DDAVP or ADH, rather than necessarily the amount of ADH that you release as well. So I think it's twofold, not that.
Okay.
But basically, you the whole point of having a well-rested patient and repeat it, and the whole reason why we have to repeat it is because we don't want that releasable pool to be released at the time of testing, because it will affect results. Yeah. We want their steady state DDAV. We want their steady state von Willebrand factor that's just released all the time, not the additional stuff that's released during stress.
Okay. Yeah.
That's a good question. Right, next one. A patient appears, is this the last one? No, penultimate. A patient appears to have a type 2 von Willebrand disease because the Rickoff to antigen ratio is less than 0.7. The laboratory technologist performs the RIPPA, ristocetin-induced platelet agglutination assay using the customary 1 milligram per mil and the reduced ristocetin concentrations 0.5, 0.25 and 0.1 milligrams per mil, respectively. A procedure called the ristocetin response curve. The technologist observes platelet agglutination at all concentrations of ristocetin. What von Willebrand subtype is most likely based on these results?
That sounds bonkers, pal.
Yeah.
So type 2B.
It's easy. It's easy. Perfect. Last one. Last one, a 20-year-old woman with a history of menorrhagia was recently diagnosed with von Willebrand's disease. Her laboratory results show markedly reduced factor 8 levels with normal von Willebrand factor antigen levels and normal multimeric pattern. Which of the following types of von Willebrand's disease is most consistent?
type 2N.
Which
factor.
Yes, exactly.
No factor.
And do you see, this is a nice contrast to that other one, because this lady has normal von Willebrand factor antigen levels. Yeah. With a low factor 8, as the other one, the antigen and the factor 8 levels were both low. Yeah. Do you see the difference as well, David?
Yeah. No, it's I was suckered into the complicated things.
You were suckered into it. It was a simple one, but because we gave you the factor 8, it got you confused.
I was lured in by the factor 8.
You were lured in. I'm glad I managed to lure you into at least one track.
We need one of those like QI alarms that you just hit every time I stumble into
yes,
something.
he fell in, finally. It's taken a long time today. Good, we're done. Okay, like, you guys have got full marks, so excellent. Do you feel happier with how to do the lab tests and what they mean and how to interpret them? Because they are your friend once you understand them.
Yeah, I'll try to retain it. I think retention of this, because it makes sense. Once it clicks, it clicks, but then it's because there's volume-wise so much.
Yeah. And I think
written out, it would be easier.
Yeah.
You can almost just chart it then, can't you? Like, does it? Yeah.
Yeah. And there are some nice flow charts on
No.
Heme-Base, for example. I think it was Heme-Base that I got this diagram. But or was it one of the guidelines? There's a von Willebrand's disease guideline with a flow chart where you can follow it. But yeah, well done. And I think it'd be worth listening at home and writing it down and going back and listening to the first episode again, the part 1, once you've listened to part 2, to re-solidify it. Because there's a lot of overlap. We've had to like artificially split this into 3 parts just because it's such a massive topic, and otherwise people will genuinely fall asleep whilst driving a car, and that okay, should we wrap up with the 3 golden nuggets?
Yes, please.
Okay, number 1, your basic von Willebrand's diagnosis needs 2 repeated lab results, like on 2 separate occasions, in a well-rested, non-stressed patient, along with a bleeding history. Okay. Number 2, your antigen, your main von Willebrand disease screen consists of von Willebrand factor antigen level, which is based on simple ELISA techniques and measures total von Willebrand factor, with a cutoff of less than 30. As your RICOF, which is your ristocetin cofactor assay, which uses ristocetin to allow von Willebrand factor to bind GP1B as a measure of von Willebrand factor's activity of binding platelets. And that's what we mean by activity, is the RICOF. It's the same thing. And then 3 is you've then got your other tests to look for the type of 2. So you've got your factor 8 binding assay, which essentially is looking at how well your von Willebrand factor is able to bind and carry factor 8 in the blood. Your RIPA, which is looking for those overactive, hyper-excited von Willebrand factor that can bind GP1B with too much affinity, and so the RIPA is essentially using really low dose ristocetin, and if it's positive, then it means that you've got your bonkers for your platelets. And 3, and your third one of your like special lab tests is you're looking for your high molecular weight multimers by doing a collagen binding assay, because we know that the high molecular weight multimers in particular are important for that lasso role of binding collagen. And so that's to distinguish between 2A and 2M. And then don't forget your desmopressin trial, both because it's clinically useful to know whether that's a good treatment for your patient if they did come in with bleeding, but also it allows you to spot those Vicenza 1Cs versus just your standard boring type 1 von Willebrand's disease. Is that 3 golden nuggets? I've lost count.
I felt like 3 squared, like 9.
Okay, sorry. My brain's fried too. So yeah. Next time we will talk about clinical management of von Willebrand's, including management of von Willebrand's in pregnancy, because that's a hot exam topic and something that we get asked about a lot in the essay questions in part 1. And yeah, in the meantime, happy listening. Go back and listen to the first episode again if you need to. And we'll see you all next time.
Thank you very much.
Thanks, guys.
Thanks, team.
Also, David's Ask the Heme questions. Do you want to?
Yeah, so I thought we would do an episode at some point where we sort of flip this on its head and bully and Harrod a little bit. And what we'd like to do is come up with some questions that
revenge.
Yeah. I would like to come up with some questions that you're too afraid to talk to your consultant about. The ones that you don't want to say in front of other people because either they're stupid.
Haematologists are so scary.
So scary. So if you want to send in or comment in the posts about any questions that you want to ask, we will fire them back at Harry with maybe a little bit of a heads up because we're not that mean.
I also feel like they'll just come right back at us and we'll have to do homework. But
yeah, that's true. Good point.
That's fine. You go ahead. Yeah.
He knows my technique. Okay, good. All right. See you later, guys.
Thank you, guys.
Bye.
Cheers, Harry.
Bye.
Cheers.
Thanks again for listening to Basics to Brilliance Haematology Podcast. If you enjoy our series, please don't forget to like, leave a review, and hit subscribe to never miss an episode. See you next time!